All right, good morning. We'll get started. So first, I want to welcome all of you to our regional geriatric rounds on this very snowy Friday right before Christmas. My name is Fred Beauchemin. I'm Clinical Director of Geriatrics and Short-Term Rehab and also Chief of Physiotherapy at the Ottawa Hospital. Today, we are very excited to have two special presenters talking about a topic that's very dear to my heart, which is the Move On initiative, which is the prevention of functional decline of our vulnerable seniors. So let's meet our presenters. First, we have Vicky Thompson. Vicky is an Australian-trained therapist with 28 years of experience and has worked in almost all areas of practice, including community and private practice. Areas of professional and clinical interest include the management of pain, both acute and chronic, musculoskeletal orthopedic management of patients, preventative medicine, and geriatrics with a strong focus on the interdisciplinary teamwork. Until September 2012, Vicky was practice coordinator at the Riverside campus, which is an outpatient orthopedic clinic. Vicky currently is working as a senior physiotherapist, geriatric specialist on the geriatric consult team. Vicky also covers the emergency at the Civic campus and is also the education coordinator for the Move On project at TOH. Our second presenter is Dr. Power, who was the chief of geriatric medicine at the Ottawa Hospital and the University of Ottawa from 1999 to 2012. She is actively involved in medical education. Dr. Power is the chair of clinical skills for the undergraduate program at the University of Ottawa, the program director for the Geriatric Medicine Training Program, and was previously chair of the Canadian Geriatric Society Education Committee and the Royal College Examination Committee in Geriatric Medicine. Her research interests are in delirium and cardiovascular disease in the elderly. And Dr. Power was previously named Clinician of the Year at the Ottawa Hospital. So I'd like to welcome both presenters. Thank you.
Wow. So welcome. I can't believe people actually made it today. Did Dr. Delcio come in his snowshoes? I think that's what he told me he was going to do. So welcome everyone, and happy holidays to all of you. So can I use the mouse to... Okay, I'll use it. Okay, it's probably easier, right? All right, so this is fun for Vicky and I finally to get to talk about this project, which is called the Mobilization of Vulnerable Elders in Ontario, the Arctic program and project. And I'll talk about what those letters actually stand for. But before I do that, I thought I'd just bring out this quote. It's from 1947, and it's actually very true for us today. The dangers of going to bed. So resting in bed is anatomically, physiologically, and psychologically unsound. Look at a patient lying long in bed. What a pathetic picture he makes. The blood clotting in his veins, of course, the DVT. The lime draining from his bones, obviously getting osteoporosis. The scibala stacking up in his colon, he's getting constipated. The flesh rotting from his very seat, the pressure sores. The urine leaking from his distended bladder, and the spirit evaporating from his soul. And we know this is absolutely true for today, and it actually lists all the problems that are associated with people who end up staying in bed for prolonged periods of time. So, what is KO? What does it stand for? And I'm just going to do a few introductory slides, and Vicky's actually going to discuss the project in much more detail. But KO stands for the Council of Academic Hospitals of Ontario, and this is the Arctic project. And I'll tell you what the Arctic project stands for. So who is KO? As I said, the Councils of Academic Hospitals of Ontario. It actually includes 24 academic facilities that are associated with research institutes. It provides a focal point for strategic initiatives on behalf of the members, and it's mainly connected with hospitals that have research-associated institutions. So, who are they? There's a lot of them. I'm not going to go through, and this is in alphabetical order, but just so you can recognize, Briere, CHEO, the Montfort, and the Ottawa Hospital are all part of KO. And our representative on KO is Dr. Jack Kitts. Usually it is the CEO of the hospitals that is the main representative on the committee. So their strategic plan, I'll go over, we'll just go and delete this slide. I moved on to these Sorry, Mary, you didn't get my latest version. These slides weren't included. So anyway, walking the talk, the KO Arctic program. So the Arctic part of it talks about adopting research to improve care. So the concept is that you have research being done, right? It's being published, but are we actually putting it into practice? And this is the concept of the Arctic program. So some of the projects that they've already done and have funded, and you may be very much aware of this, is the Handy Audit tool. That's got to do with documenting hand hygiene. The Canadian C-spine rule, again, many of you may be aware of this project as well. And for 2011-2012, the two projects that they've funded are the Move On and also the Antimicrobial Stewardship Program. So it's a self-funded initiative. The academic hospitals actually fund these projects, but because they're doing such a great job, they've actually received in the past year $6.3 million from MOH to help fund these initiatives. So the first one, I thought I'd just briefly mention some of the projects that have been done. I'm sure, again, you're quite familiar with this Handy Audit. So this project, again, was based on a research study that was done in Toronto and then rolled out across the province. And that's why we got to the level where we were documenting the use of doing hand hygiene, using it on iPads and iPhones. And this is all through KO. And I just want to backtrack a minute to say, isn't it interesting that in this day and age we have to tell physicians and staff to wash their hands before they see patients? It's kind of interesting how we then have to change a culture. And Move On is not dissimilar. Mobilizing elderly patients should be standard of care. And now we actually have to do a project to show that it's of importance. So it's interesting how things come full circle. So the other project KO funded as well is the C-spine rule. Again, this was based actually on a decision support tool that was developed at the Ottawa Hospital. I think Dr. Ian Steele was the head of this. And this project that was rolled out last year was to allow nurses in the emergency room to remove a patient's cervical collar without the need for an X-ray. And there was a whole decision algorithm that was created. And this was rolled out throughout 9 hospitals in the province. Project 3 is the Antimicrobial Stewardship Program, and many of you may be familiar with this. This is being done in the ICU, and the Ottawa Hospital is part of that program, and it's being led by Dr. Gary Garber. And they're trying to steer and give direction as to what antibiotics should be used in what situations in an event to decrease resistance and obviously reduce cost. So finally, Move On. What is Move On? It's a project, hopefully, and we're sure and positive it will implement. It's to implement and evaluate the impact of an evidence-based strategy to promote early mobilization and prevent functional decline in older patients admitted to acute care facilities in Ontario. Now, as I said, these projects are based on previous research. So Move On was based on Move It, which was mobilization of vulnerable elderly in Toronto. So they've already done research to show that this does have a positive outcome, and hence that's why it's being funded province-wide. So just think of a case. Oh, sorry, Marion. Again, these aren't the same slides. But anyway, just think of a case. I'll make it up then. It's got to do with Mrs. L. A typical patient. She comes into the emergency room. She's got a urinary tract infection. She's had a fall. She's actually in the emergency room for a couple of days, and while in the ER, she's not mobilized. She eventually gets to the floor, but it's Friday evening. She's not mobilized all weekend, and of course Monday comes along and the physiotherapist comes to see her, but in fact the physio maybe can't get to see her until the afternoon. So maybe 4 or 5 days have gone by without this lady being actually mobilized. So this is a case that we're all quite familiar with. But the question and the barriers that Vicky's going to talk about is it really feasible? And how easy is it to mobilize the frail older patients on medical units? Because this is the type of situation that people run into. Someone who's very frail, maybe they're delirious, maybe they have a dementia, they may be a 2-person, 3-person transfer. So it's not easy. We don't pretend that this is going to be an easy program to initiate, but hopefully with time we'll change attitude and we'll change a culture. We certainly know that early mobilization does work. It's been shown not only in the MOVE IT trial, but also in other studies to show that early mobilization of vulnerable elderly actually decreases length of stay. It shortens the duration of delirium. It improves return to independent functional status, decreases rate of depression, increases rate of discharge, and of course, with all of these benefits, overall decreases costs. So if you think of that early quote about the patient who's lying in bed and gets constipated, pressure sores, deconditioned, and urinary retention, there's no question the research also shows that these kind of problems can be addressed and potentially prevented with early mobilization. So the potential solution that Vicky's going to talk about is the Move On project, and I just want to highlight this study that was also published in JAGS, where they looked at over 2,000 patients and looked at their ADL at baseline, and then within a few days of admission, 43% of them had a decline in their independence in ADLs, quite dramatic. And then by time of discharge, there was some improvement, but still 35% of patients had a decrease in their ADLs compared to baseline. And off those 35%, 5% never returned to their previous ADL level of function. So again, it highlights what hospitalization does to elderly people. Obviously, it's wonderful, it's great what we all do. We treat acute medical problems, but we can't forget about something very basic like washing our hands and getting people out of bed. So with that introduction, I'll let Vicky, our champion leader, who is really amazing, and it's great to have her on this project, because I'm sure she's going to get us all moving on. Okay.
Boy, no pressure there, Barb. Okay, thanks everyone for coming, and it's again, I will echo Barb's statement. You're obviously a dedicated crew to get here with this weather, and on only the fourth last shopping day before Christmas. So I appreciate that. I'm very passionate about this project, and it's not just because I'm a physio and I've been moving people for years. This is a no-brainer to me, and covering Emerge, I often see patients who have been in Emerge, who have been admitted but can't get a bed, and are down there for 2 to 3 days, and just watching the decline in their status over that period of time is phenomenal. And certainly getting our patients moving faster and earlier is of benefit not only to our patients but to ourselves as well, and for patient and family and staff satisfaction. So Move On, as Barb has already mentioned, the mobilisation of vulnerable elderly in Ontario, and I don't need to repeat the fact that this is an evidence-based strategy to promote early mobilisation. I'm going to tell you a little bit more in detail about the phases of the project and how we've rolled it out through TOH, and we'll be rolling it out. So some numbers to consider. In Ontario, seniors account for about 20% of ED visits, and I would say on some days, even more than that. 56% of acute hospital days and 83% of acute ALC days. We know that, as Dr. Powell mentioned, on average only 43 minutes per day is dedicated to moving or standing once patients are admitted, and a third will go on to develop that new disability. We know that our senior patients are already starting to have some loss of muscle mass, so putting a patient to bed, they will lose between 1% and 5% of muscle strength per day, and only a third of our senior patients are mobilised regularly. Hospitals are great places to be when you're sick, but hospitals basically do encourage immobility, and there are a number of reasons for that. The hospital environment, the way we say to our patients, don't get out of bed, use the call bell. We encourage that dependence on the staff. Mobility orders can be unclear, or changes in mobility status may not be conveyed in a timely manner. And then there are other intrinsic factors too. In terms of staffing, we're busy. There are processes, there are protocols, just moving patients through the system from one service to another. There can be delays as well. So the Move On project has basically 3 phases. There's 4 phases actually. The first phase, phase 0, was the planning phase. So that started with getting the ethics approval, and there was a little bit of gymnastics that went on with that, and we did get approval on October 5th of this year. Was then to engage our key stakeholders, which were the units that were going to be involved in this project, which here at TOH is A1, our geriatric assessment unit, and B5, one of our very busy medical floors. We created a local move-on working group consisting of the unit managers of those two units, Janet Hansen and Karen Lawrence, and our nurse educators on those units, Diana Hughes and Irene Oliveira. We also had our physician leads, Dr. Power and Dr. Lara Curry, as well as Fred Bolsherman, our Chief of Geriatrics, myself, and our research coordinator, Jan Michael Charles, who unfortunately is not here today, but he's doing a stellar job as well, and I'll explain a little bit more about his role. So our patient population is 20 patients on A1, and we have 24 on B5. We have just today is our final day of phase 1, which was the pre-intervention phase, and this was of 10 weeks duration. We started this on October 15th. Part of Jan Michael, the research coordinator's role, is to conduct audits. So he has an audit tool that has been developed through the Central Steering Committee in Toronto. And he goes out onto the units twice per day and has been doing this for the past 10 weeks. And he conducts a visual audit of the mobility status of patients on the unit. So that happens 3 times per day. He also then conducts a chart review where he goes into the chart and a discharge patient's chart, and from the chart tries to extrapolate evidence of mobilization. And that, for those of you who are familiar with the medical charts, that can be quite a challenge because we don't really have a clear documentation tool that captures all the mobility events that may be occurring with a patient's stay. The physiotherapist may document something, there may be something in OT, there may be something in the nursing notes, but there's no one central area. So he has reported that's been quite the challenge. We also conducted focus groups during this period. We had 5 focus groups where we went to each unit and had a cross-section of staff in 2 different, actually it was 3 meetings on B5, 2 on A1, where we basically asked the staff, what are the barriers to mobilising patients, and I'll expand on this shortly, and what are the things that make it easy for you to mobilise patients? And before that, do you even buy into this? Do you think it's important that we move patients? We also at this time have developed a number of posters that will be put onto the walls of the units. We've created 2 modules that will be going onto Elm, so patients can, so staff can go onto through Elm and do some online learning. The focus groups, like I mentioned, so the barriers, and this is what the staff identified. Certainly, understandably, not enough staff, not enough time, too many competing initiatives, and people are tired. Like some of the units there are so many things that are coming through the system, new initiatives, new protocols, that there's a little bit of new initiative burnout occurring. Staff may not be working to full scope. There is a bit of an attitude at times that that's not my job, that's someone else's job to get the patient out of bed. We have that reliance on 1 or 2 team members, typically PTs, physio assistants, PCAs, who are designated as the people movers, OTs as well. We do have an inconsistent approach to staff mobilising patients, and by that I mean one staff member said, well, one patient will say to me, oh, you're on today, that means I have to get out of bed. I liked that other person who was on because that meant that I didn't have to get out of bed quite so frequently. So there is an inconsistent approach to the standard of moving our patients. There is a Monday to Friday 8 to 4 approach because, as we know, not all the team members are here in the same numbers during the weekend. If a patient has a setback, it was identified as a barrier because staff would withdraw from mobilising that patient instead of perhaps changing the focus of the mobilisation. And there was a tendency for, it was mentioned, morale, things are never going to change. Here's another change that you're trying to institute. That whole change philosophy was seen as a barrier, identified as a barrier as well. In terms of the environment, we certainly, again, space is always an issue, both in the patient's room and in the hallways. There isn't any designated exercise space, and on some units not even a designated place where patients can get off the unit to sit. Equipment, using equipment, competence in using equipment such as lifts, broken equipment, and communication boards. And every patient room has a communication board. We're all familiar with those. one basic barrier was the fact that the marker that is used to put information on the communication board was often missing. And there was problems at times updating the information and who was the delegated person to update information about the patient's mobility status. In terms of patients, we know that patients are sicker, they're more complex. There can be problems with the size of patients and having the appropriate equipment for those patients. Mood and cognition, if a patient is depressed, they're not really going to want to get out of bed. And if they're delirious or there is some confusion, or sometimes a patient will say, well, yeah, I have been out of bed. I got up this morning with so-and-so. I went for a walk with my family, when in fact they haven't. We don't often have a way of capturing that. There can be that culture and attitude from family and patient that, my father's admitted and he's sick, so we're just going to keep him in bed and let him get better, and he can stay there. And sometimes just patients are busy as well. They're off at tests or procedures and harder to get to. So this is from the information that came out of the Toronto project. So pretty much the same that I've already mentioned. Again, having invasives like IVs and Foley's tend to make it a little bit harder. So I won't really go any more on that. I've mentioned all of those. In terms of the facilitators, what makes it easier to mobilise our patients? The staff identified having senior management and having the unit management leadership on board is really important. Having a mandate, having a culture that promotes mobility. As Dr. Power said, this is just a basic standard of care. Like we wash our hands, we move our patients. Getting the doctors involved was seen to be a big facilitator. One nurse mentioned that, on medicine, often there are a group of seven physicians between the residents, the staff man, students that will come into a patient's room, but no one ever gets the patient up. You rarely see that group of 7 getting a patient up. So if we could get the doctors on board, and we do have a program for that, a strategy to address that, that would be a great help as well. Having clear and up-to-date mobility status in the vicinity of the patient. It was felt that if I have to go to the chart to find out what a patient's mobility status is, what I can do with the patient, is a bit of a barrier. If it's clearly defined next to the patient on the communication board, was thought to be probably the best place. And then having that team approach, and there's a very strong focus on the Move On project that the entire team is involved in mobilising patients. For example, it's not just the nurses, the PCAs, the PTs, the OTs, the PT assistants that get the patients up. If a social worker is going to go in and do an intervention with a patient, and we know from clearly delineated communication that that patient can sit and be out of bed, then it would be great for our social workers to assist in facilitating that. That's going to be a little bit of a hard sell, but I've already talked to the social workers. Their other role there will be to really drive that message to patients and to family that it's important that their family members get up and move. If anything, if we can have that message, then that's really important. And the other thing too is that as a team, we're all documenting clearly in the chart that a patient was mobilised. I just want to also expand on what do we mean by mobilise in the Move On project. Mobilisation is not just walking the patient. Mobilisation is anything that doesn't have the patient flat in bed. We know that some of our patients are very sick and for whatever reason they can't get up out of bed, but being engaged in an exercise program that they can do in bed with either a team member or with family, having the patient sitting up with the head of bed is considered better than completely flat if they're medically stable. Having a patient dangling, sitting up in a chair, whether they need to have a mechanical lift, assist them up to a chair at least once per day is the goal with the Move On project for those heavier patients. And of course, walking the patient with or without their mobility aids. In terms of other facilitators, we had the environment. If we could decrease clutter, if we could have communication boards updated, clear mobility status, and on A1, one fabulous nurse said, well, on A1 we have a no bedpan policy. So that's their strategy. No bedpans, patients are walked to the washroom. A1's a special unit, we know that. And in terms of patients, getting family involved, again, as another idea from A1, patients there have pink passes which are attached to close to the patient's bed, and the pink pass indicates to the family that this patient can get up and walk with their family members, and it's safe to do that. So the family members are encouraged to walk the patient in the evenings or during visiting hours and on the weekends. And there was also another suggestion of having a mobility journal that patients' families could document in their progression through their stay in hospital. Phase 2, which starts January 7th, this is where we deliver the intervention. We have a number of classroom teaching sessions which will be conducted through the units, where we're basically delivering the information about what is Move On. We have a very aggressive occupational health strategy. They've been very pro Move On, and we're going to be having at least 3 times per week for the first 4 weeks of the intervention. Occupational health is going to be involved in transfer training on the units for all staff, as well as having like a drop-in component where they'll be actually on the unit and there and available as a resource if staff are having any issues with mobilising certain patients, if there are any challenges with equipment. We'll be continuing to conduct the audits. That the whole audit collection goes on throughout the entire project. The key messages of all of the education interventions to staff is that patients need to be mobilised at least 3 times per day. It should be progressive and scaled. By that, we're meaning that they're progressing through being perhaps, an assist of 2 to a chair, an assist of 1 to a chair, an assist of 2 to walk, 1, the progression through there. Mobility assessments should be implemented within 24 hours. So within 24 hours of admission, we want to know how that patient moves. And we have to ensure that these mobility events are documented in the chart. In terms of our intervention, we have several strategies. We've recruited our opinion leaders, so we have our unit managers on board. We have senior management on board. There's a very strong there's a lot of buy-in from senior management. We've got an aggressive marketing campaign as well with certain posters. We've got our Mobility Champion buttons. This is one of the posters that has been developed. This is more for staff because the language is more medical. And then this is the poster that will be going up on the units. We have French and English. And these will be on the units. In terms of the progression of mobility, if we can mobilise our patients in ICU, so this is just an example of the progression of mobilisation. So dangling, then to chair, and then mobilising with all the equipment. Our other part of the intervention is the communication. So the geriatricians and the CTU medicine staff are going to be involved in the project. And as I said, we have a strategy in place to get our our residents, I think, will be exposed or introduced to the Move On project. I've already spoken to all of the discipline-specific health professionals, so they're very much aware of this project that's coming down as well. Nursing and the PCAs will have specific on-the-unit education. We also have a very comprehensive media plan. For some of you who've read the first What's Happening instalment, there was an introduction to the Move On project through that. We also will have, that's going to be happening pretty much every time there's a What's Happening, there'll be a little update on what's happening with Move On, the same with the journal as well. In terms of the strategies, like I said, the assessments of mobility will occur within 24 hours. Mobility status will be clearly identified and updated on the patient's communication board. The mobility status is also going to be communicated through things like bullet rounds, hourly rounding, handovers, discharge planning rounds. And in terms of ensuring compliance on the units, we're looking at how we can make this an accountable process. So there's the potential for the mobility to be added to the LEM goals for managers, still in the planning process, and also for our clinicians, adding it to the goal setting on their yearly performance reviews. And we'll have a strategy in place to provide ongoing coaching for staff. In terms of further strategy, we have the most important event that we really want to reinforce is the importance of documenting mobility events, because with this project, if it's not documented or it's not witnessed, it didn't happen. And as I mentioned, we have an aggressive occupational health transfer training program. There's going to also be some family education as well to ensure they get the message of the importance of early mobilisation. So the goals of our education intervention in this next phase that starts on December 7th is to get 100% buy-in from our stakeholders and opinion leaders. So I'm actually going to be a very small but loud presence on B5 and A1 for that 2 months of the intervention strategy. I liken myself to a small terrier attached to someone's trouser leg. I won't be letting go, and you'll see a lot of me. We want to have 80% of the staff attend the education sessions. So we do have a rolling process of a rolling calendar of education sessions. 80% of staff will be involved in the transfer training. We'd like to capture 100, but if we can get 80%. Also 80% of compliance with the staff for the online learning modules, and 100% compliance from our unit leaders. 100% of patients are going to be mobilised 3 times per day, unless there are extenuating circumstances. We want to have congruency between the communication boards and the chart, and the integration of mobility as just a unit process, a basic standard of care. So phase 3, which is the final phase, and that's the evaluation, that lasts for 5 months, from March 4th to the middle of July. And at this point, our research coordinator will be continuing to go into his audits. So we've looked at what we're doing now. We'll deliver this very aggressive intervention, see if there's any changes during that time, and then in the evaluation process, see again if our intervention has created any change through the audits that Jan Michael will continue to collect the data on. There is a plan also that we will roll this out to other medicine units. One of the other tasks that Jan Michael is involved in is what we call the exit interviews. So he will be contacting families and staff members through an interview process to get information from them about their experience with the Move On project, and that data all goes to the central steering committee in Toronto for collection. So those are the exit interviews, and it's basically 20 participants on the 2 units that he will be following up on. In terms of our measurement outcomes, we're looking at the frequency of mobilisation through the audit process, the number of mobilisation events, again through the chart review, the length of stay in days, the incidence of falls, the functional status at admission and at discharge, so in terms of their ADLs and IADLs. The discharge destination are the percentage of patients that go to a location other than that word that I'm not allowed to say, and the perception and satisfaction of the patients and the families through the exit interviews. And that's it. Okay. Dr. Power actually wants to say something. Yeah.
So, thanks, Vicki. So, the first question most people ask Vicki and I is, are you hiring more physiotherapists, right, to make this project happen, or physio assistants? And this is a knowledge translation project. Unfortunately, we're not hiring more staff. I guess that's number one. What we're trying to do is change a culture. And just like with the hand hygiene, there weren't more people that were going around reminding us as staff to wash our hands. It was changing a culture. And it only really happened when the stats started to be published. And we found out the compliance rates on certain wards were 24% and 32%. People got on board because we were embarrassed into being better at washing our hands. And then the stats not only got published for our individual wards, they became public knowledge as to compliance rates for hand hygiene. And that's really what this project is about. It's knowledge translation, it's changing a culture, it's changing an attitude that it's not okay just to leave old people in bed. And it's not just the responsibility of the physiotherapist and the physio aide to mobilize a patient. It's my responsibility as a physician to try to change that culture. And I think Vicki's comment is a very good one, that as physicians going in to see a patient with house staff and students, that there may be a bunch of us hovering over a bed, and we may not even think that it is our role to get the patient up and maybe help that patient sit into a chair. So we recognize this isn't going to be an easy project, because the first and biggest barrier will be that people will say, you're not hiring more physiotherapists to do this job. But it shouldn't be that it's just the role of the physio, that it's the role of all of us. So I just want to make that clear, because that is the number one question we get asked. So with that note, it's positive, but we recognize there'll be some barriers along the way as well. And just also to highlight that the MOFOR has also introduced this project, and they've already started, and they're a little bit further along than we are already on this initiative. So it's also great to locally have another hospital that we're collaborating with on this new concept. Yeah, thanks. Yeah.
So yeah, just maybe a huge thanks to Dr. Power and to Vicki for coming out, especially on a day where we're, I think that there's 10 or 15 centimeters on the ground and another 25 to come over the day, and for all you folks for coming out to see this excellent presentation. We'll open it up for questions and comments. I did have a comment, and I think one of the things that we have to reflect on is that if we look back at the genesis of Move It, it actually originated from the whole concept of the senior-friendly hospital strategy. And one of the building blocks within that senior-friendly hospital strategies is the processes of care. And we know provincially it was identified that the two key initiatives, delirium and functional decline, there's strategies underway to address that. And one of the strategies to address the functional decline, but also supports delirium, would be the Move On. That's a collaborative, provincial collaborative that's being led by provincially by St. Mike's and by Sunnybrook. And Dr. Barb Power has been a champion for this over the last several years. And so I think kudos to that group to get this moving forward and moving it here within the Ottawa Hospital. So if there's questions we'll start with the satellite sites. If there's questions from that group. You can unmute your mics and then ask the question, and then we'll get either Dr. Power or Vicki to answer your questions.
This is the Queensway Carleton Hospital.
Okay, go ahead, Anne.
My question is about the transition of the project from a project to an ongoing way you do business. Has the group thought about or made a plan for both spread and sustainability of the interventions that you're going to be trying out?
Yeah. Okay. So one of the great we got some very exciting information several months ago, actually, that the LHIN is going to be providing us some funding for 2013 to 2014, which will enable us to hire 2 more people to assist with the rollout of this project. Once we have completed the project and we've reviewed the process and we can look at what we can tweak, what we can improve on, the plan is certainly to roll this out through the rest of beginning with the medicine floors here at the Civic and the medicine floor at the General, and to basically roll it out through the entirety of TOH. As we said, the message is that this is a basic standard of care. We're not going to have one unit mobilising patients and other units not mobilising patients. So we'll have the 2 extra people to help us with this rollout. But yeah, this is where it's going to be going and growing.
Thank you. So you addressed the question of spread. I'm just wondering about sustainability. Will your evaluation period help you identify, is that part of your plan, to identify what you would need to put in place to ensure sustainability?
That's certainly going to be a big part of the evaluation, and we're also we're lucky to be able to have the support and the feedback from all of the other hospitals that are participating in the project. So we can look at what's working in our partner organisations and put that plan in place. I'm not exactly sure how it looks right now, but in terms of accountability, if we're attaching things like the number of mobilisation events to our unit managers, goals, if we're putting it into our yearly performance reviews for staff. If we're going to have some way of tracking stats, which I think at some point is going to be very important, that we look at numbers. And as I said, it'll be basically a basic standard of care. Did you want to add anything, Bob?
Thank you very much.
I'll just add to Vicky's comment, is because this is a project through CAHO and also connect it with the Ministry of Health, we will have to report on the stats, and since it will be rolled out throughout the hospital, the concept is that it may get to a level similar to hand hygiene where we will have to report on these stats on a regular basis, so hence that will lead to the sustainability of this project, and as Kelly mentioned, it will be linked to a senior-friendly hospital, so that will be part of the sustainability of the project. Thanks.
Yeah. And just maybe to add to that is that there is a provincial indicator working group that's actually going to be sending out in the new year requests for hospitals to participate in a pilot of indicators for functional decline and delirium, and the indicators that have been identified through the Delphi process align quite nicely with the Move On project. So I think there's opportunity there that sustainability will be built in through those metrics that have to be reported on by the hospitals across the province. Are there other questions? Locally?
Hi. Toronto East General Hospital.
Yep, please proceed.
I'm a dietitian, and I'm a firm believer in terms of mobilizing patient. However, I wonder what would be the liability for us to help patient get out of bed and walking and so forth.
Well, we're certainly not expecting our dietitians and speech-language pathologists and psychologists to haul out an overhead lift and get a patient out of bed. That's certainly not the expectation. What we're trying, this is a total team approach to the care and the mobility of a patient. So what we would be asking our dietitians is that if a patient is able to sit and sit up, that the patient be put into a chair. Now, that may be done with the aid of a physio, with a nurse or a physio assistant, but our nursing staff as well. But we're certainly not expecting you to be involved in a heavy transfer of a patient. If we know that a patient can sit, then that would be great if you could do your work with them. We know that for our speech-language pathologists, having a person in a good posture, sitting for their meals is important. What I would say to our dietitians and speech-language pathologists and other allied health professionals who are not that heavily involved in physically moving patients is that you do document that if a patient was up in a chair when you had your intervention, that is written in your notes. What we will often see is that patient was seen by dietitian and education given. Well, if we could have that a little bit more specific, like patient was seen by the dietitian, patient was sitting, that's a mobility event that we can capture. That's a metric that is valid. I'm not sure if that answers your question.
Thank you.
One other thing too is the communication board that we use here at TOH beside the patient's bedside will have the clear status of the patient in terms of their ability to sit or the assistance required.
Yeah, go ahead, Dr. Dawson.
While I agree with you that attitude and culture are the key thing, staff time is a real thing. Much of it's perceived like, oh, I don't have time to exercise, but there is a real staff time issue. And I wonder if you consider in the next phase looking at a volunteer component. We encourage and empower family to walk patients. Why can't we do the same thing with volunteers? I've spoken to volunteers. They would find this much more meaningful than handing out sweets and books and stuff. And I think it would then really motivate the staff if they're dealing with the lower level of mobility patients, and if they graduate someone, the volunteers can take over. I think that's much more likely to succeed than just sort of saying, here's another thing, you just do this as well as your other things. The second comment I have is about quad exercises. When I go around the wards, I ask patients, what have you been taught to do in terms All I ever get is, oh, I'm supposed to move my ankles around to prevent DVT. Why can't we incorporate something like that? The question for the dietitian, she could be asking the patients to lift up their legs, quad exercises, while she's doing an interview. That would be incredibly powerful. So I encourage you to consider that. You may already have. But it's a simple, discrete thing that takes like a minute to do quads each side.
I'll let Vicki answer the second part. I can address the first part. Around the volunteer programs, there is models that have been presented here at the TOH's Senior Friendly Hospital Committee around the HELP model, which is Dr. Sharon Inouye's work, where it incorporates the volunteer concept. And I think that is being looked at more so in terms of how we can move that forward. Dr. George Heckman actually did a really a project down in Waterloo Kitchener where he looked at the HELP model from a really feasibility, scalability perspective and presented that to the LHIN in his region. And the LHIN supported then 5 or 6 of the hospitals in that region to implement the HELP model because there is a bit of a financial challenge there in terms of supporting someone to coordinate and train and manage the volunteers over time. And then I'll let
the cost for that per 100 volunteers is negligible compared to trying to ask staff to really do a major effort. I think it's the only way you're really going to succeed is if you build volunteers into this model. And why not?
I definitely agree with you.
With something built into this rather than a whole giant help.
Yeah.
Thanks, Dr. Dalziel. The point well taken. We recognize the tremendous value and importance of incorporating volunteers. It's the same concept with the Senior Friendly Hospital, as Kelly has mentioned. There are some challenges, though. We've certainly been explained and told about with working with the volunteers in the sense that many of the volunteers themselves are now becoming elderly, and so there are some issues around that. There's issues around liability of mobilization of patients with volunteers. There's issues of the fact that many volunteers go away for the winter season, and so the numbers of volunteers tend to drop off. But we've been trying to work with the TOH volunteer program, and they are part actually of the Senior Friendly Hospital group. So we're very much aware, but there are some definite challenges, but hopefully lots of opportunities. But lots of opportunities as well. So we'll move on, and I'll get back. Yeah, and so the second part about the exercise program, I guess I'll have to leave that one to the physiotherapists and to Vicki about educating staff about doing more exercise beyond just rolling ankles. I think that's a very good concept. But hopefully with the communication boards that will be by the patient's bedside, this will actually highlight what a patient is able and capable of doing. And so that communication board is meant to be there for all allied health, including dietitians, so they'll be made aware and be able to understand whether a patient's able to sit up in a chair or sit up, etc. Obviously, I think for a dietitian too, it highlights the importance that nutrition, intake, appetite can all be improved if someone is moved rather than just lying in bed, etc. So that's another method. Yeah. Dr. Molnar, you have a question? Then Linda? Yeah.
I'm curious about the physician component of the intervention. When this was designed in Toronto, as physicians are asked to get people out of bed, are they also asked to assess basic barriers to mobility, such as positive hypertension or pain management? So looking at the epidemiology while they're mobilizing or referral to a service like geriatrics if the cost is not clear. Is that ever built in, or is that something that would be integrated down the road?
Yeah, that's a very good point. Dr. Molnar was raising the issue in terms of the education rollout to physicians. Could it also be added that in the concept of evaluating a patient with regards to their mobility, can we educate house staff about the importance and value of looking at postural hypotension? And also it's a great opportunity to objectively observe your patients as to problems related to pain. We haven't actually highlighted that, Dr. Molnar. We have sort of a strategy of educating residents. Keep in mind that our target area to begin with is just B5, so it's a relatively small group, but it's certainly something that we should add on into that teaching. And maybe then the residents and physicians will be more likely to buy into the process because then they think there's a medical component to it. So that's a very good suggestion. Very good. We'll add that to our slides. Yeah. Linda had a...
I just want to congratulate you, and I think it's great. And I'm wondering, the projects that do well, I'm wondering if the model of nursing care is different. Because patients have become sicker, and over time, models haven't really changed. And I'm wondering, on the units that have succeeded in Toronto or wherever, is the model of nursing both theoretically and clinically different? Because on surgery, when you go to surgery, it's already built in. The nurses get the patients up, spirometer, get walking, get going. And on other services, it's not sort of the same mentality. I'm wondering, is there a difference in that? I think you'll notice.
Yeah, so the question was, is the model of nursing care different, or was it different on the units that were involved in the Move It project in Toronto? So was the culture, or were the expectations, I'm just rephrasing your question, different from the nursing perspective? Because Linda gave the example that on surgical floors it's become standard of care. Nurses know to get patients up day one post-op, and because they want to get their bowels moving, et cetera, the old concept of the post-op abdominal patient. You know what? I don't actually know the specifics of the answer to that question. I do know from the various sites that are involved in this initiative, the Move On project, that the champions in some sites are actually nurse educators. And we recognize that one of the big groups that obviously have to be involved in this initiative are nurses, because they're the ones who do 12-hour shifts. They're the ones that are at the bedside all the time. They're the ones that have the opportunities to connect and communicate with families. So because of that, one of the big things is part of our project is that we put in a proposal to get funding for a nurse educator to help with the rollout of this program, because we feel that that we need a really big nursing champion to make this actually work. So thanks for that comment. Yeah, I think first we had here, and then Dr. Assad. Yeah.
Comment about the whole documentation. As a physio, I document in about 4 different places. So I'm doing assessments, interpretive notes, the whiteboard, and doing the cardex. And I think we have to be careful that we're not kind of increasing the workload with too much documentation. Because if the nurse is being told that she has to get the patient up and then document it every time she does it, I think you're kind of doubling the amount of work and you're making it seem bigger. As a physio, it's getting to the point where I'm documenting the same thing in so many different places, and it's getting to the point where it's documented everywhere, but now it's getting people to look at. So I think just with the documentation, I realize you need it for the study aspect of it, but if you can make it as easy as possible or as quick as possible, because I don't think it's realistic to think that every professional is going to go get a patient up and then document it in the chart every time, because then it's leading to a huge burden in terms of, I have 5 minutes, do I get the patient up? I don't know, I've got to get the patient up, then I've got to document it, that's 10 minutes long.
Yeah. Okay, so Marie's question was around documentation and the amount of time that it takes to be doing that, and the amount of documentation that everyone is doing. That's a great point, Marie. We've already looked at the documentation as a huge issue, and it has been for a lot of the other sites as well. We're wanting to develop a documentation tool. We have, on the units, when I went and sort of walked through the Civic Campus about a month ago, and I went on with the premise that if I go onto the unit, how do I find out how a patient moves? Where do I find that information? And how would I know how to get how a patient is doing? There is no consistency at all in any of the units. Some units are very strongly focused on the cardex. Some units are not. Some units use the whiteboard, the communication board, for mobility status. Some don't. There is no. Some people assume that the physios are updating the unit boards. That doesn't always happen. Some units use little transfer papers at the head of the patient's bed. Then the patient goes off to a test. They come back in the bed, but the paper is no longer there. Some units rely on just the physio notes to find out. For the most part, people will say, well, I go and ask the PT how the patient is moving and whether they've got up today. So there's no doubt that the documentation we have to address that. We have a couple of models that we're looking at. Every unit has a daily rounding flow sheet that is attached to the outside of the door. We're looking at potentially using that. The other most likely tool that we will use is the 24-hour flow sheet, which is attached to the black clipboard, which is outside every patient's room. There's actually a mobility section in there that is very rarely completed. So we're going to be strongly encouraging in the education part of the intervention that is completed, and that's where our nurse educators come in. I did meet with the nurse who's involved with care plans and the pathways to look at could we develop some kind of documentation tool. It's pretty much, we have so many pieces of paper in the chart, we really don't want to create something else if we have something that's already there and just isn't being used. So we're going to be strongly encouraging the 24-hour flow sheet.
So we have time for one more question. Dr. Sad, last question goes to you.
General.
Oh, the general campus?
Yes, please.
Okay, we'll get to the general for the last question.
Thank you.
Yeah.
And one of his complaints is he's not being mobilized enough. And not that we are not trying. So since we're talking about knowledge transmission, I was wondering what the state of knowledge in relation to the target mobilization, recognizing that we want to get these people out of the hospital as quickly as possible. What is there evidence of the target? Like, mobilization, you said progressive mobilization. Is there a target that has been shown when they can, let's say, walk 40 meters? That's the target. Does that translate into dischargeability?
It's a great question. And the short answer is we don't know. Does someone have to walk 40 meters, 50 meters, 100 meters? I guess a lot of it's going to be dictated to a certain extent of where they live, right? But and just like the concept, do you have to do stairs, is going to be dependent, do you need to do stairs to get home? As far as the Move It trial, the target was the patient had to be mobilized a minimum of 3 times a day. And so that was their target that they reached, and provided the patient reached that target, it did make a difference in terms of length of stay, et cetera, and earlier discharge. But as far as the distance, I'm not aware of anything from the literature that actually states that there's a minimum distance you have to reach in order to make it at home, because I think so much of it is dictated by where you live. Some patients, as you know, will say, I just need to be able to transfer the patient, and provided they can transfer, I can take them home. So, that's a very good question. So, last question to the general campus, and sorry that we didn't go there. And Kelly, do you know how to? Okay, yes. Hello?
Sorry, it took me a little second to figure out how to use that. And sorry about my exuberance earlier. I just think this is a great idea. And I'm very excited about the Move On project. So my question is more of a comment. Would it be possible to put the mobility status of patients on the CPOE, because everyone has access to it? And we could, write 1 assist, 2 assist, 1 assist.
That's a great question, Elise. I'll let you develop that tool. I will help you. Energetic
I would be pleased to.
Great. Okay, I got a champion. That's certainly potential. I think there's a lot of potential for having like some kind of electronic device, like the hand hygiene audit tool almost, but. We'll certainly take that into consideration, and I know there's so many fantastic ideas out there amongst all of you, so please don't hesitate if you have any ideas, any comments to let me know. You know where you can find me, or Dr. Power. Thanks, everyone.
So once again, a huge thanks to Dr. Power and Vicki for an excellent presentation. And just a quick reminder, our next rounds are January 18th. Dr. Linda Lee from Waterloo Kitchener will be presenting Building Capacity for Improved Dementia Care Within Primary Care. And just to note, there will be no video conferencing available at the general campus, so you'll have to do the travel to the Civic or see it on the RGPEO website. Please hand in your evaluations on your way out, and OTN participants can get the form on the OTN site. If you cannot read the handouts, you can go to our website, and there'll be the handouts there probably early next week or maybe a little bit later because of Christmas. And wishing you a Merry Christmas and a Happy New Year. We'll see you in the new year. All the best.